This is Shahjahan Ahmad, and I'll be talking about minimally invasive TLIF and posterior approaches to the spine by Shahjahan Ahmad, Ryan Khanna, and Richard Fessler. The objectives for this chapter are to appreciate the advantages of circumferential stabilization with the transforaminal lumbar interbody fusion, or TLIF technique, to understand the indications for minimally invasive TLIF, identify the advantages and disadvantages of an open versus minimally invasive approach, and compare to other approaches for interbody fusion, to review the operative techniques for a minimally invasive TLIF, and finally to understand complication avoidance during the procedure. There are many advantages to an interbody fusion. They allow for 360-degree stabilization when combined with pedicle screws. The posterior lateral interbody fusion, or PLIF, and the TLIF both allow for interbody placement and posterior fusion through a single posterior approach. Some of the advantages of a circumferential type fusion versus a posterolateral fusion include a larger surface area for fusion, given the graft in the intervertebral space, an enhanced fusion via significant compressive forces on the graft itself, and restoration of intervertebral disc height and segmental lordosis, therefore causing indirect decompression of the neural elements. The indications for a minimally invasive TLIF are similar to the indications for an open TLIF. They include low-grade 1 or 2 spondylolisthesis, degenerative disc disease causing discogenic low back pain, recurrent disc herniations causing significant mechanical pain, post-discectomy collapse with foraminal stenosis and radiculopathy, post-laminectomy kyphosis, and lumbar coronal or sagittal deformity. These upright flexion-extension lumbar x-rays show a mobile spondylolisthesis at L4 and L5, which reduces on extension. This pathology, when causing back pain, is one of the primary indications for a TLIF. Careful patient selection must be done to determine if a surgical candidate is more appropriate for an open versus minimally invasive procedure. In general, the advantages to a minimally invasive approach include reduced blood loss, reduced operative time, lower transfusion rates, and decreased postoperative narcotics. These benefits are primarily due to reduced retraction-induced ischemia and muscle dissection during minimally invasive approaches. On to the surgical procedure. The equipment needed for a minimally invasive TLIF is similar to that for an open TLIF. This includes C-arm fluoroscopy, laminectomy tray, high-speed drill, tools for end plate preparation, and an interbody graft. In addition to these, the minimally invasive approach requires a tubular retraction system, tools which are modified for use in the tubular retraction system, as well as percutaneous pedicle screw system. The patient is positioned prone on a Wilson frame and Jackson table. All arm joints are bent to less than 90 degrees and placed alongside the patient's head. The knees, axilla, elbows, and wrists are carefully padded. The legs are elevated with pillows to reduce stretch on the sciatic nerve. The face is placed in a padded mask that has a mirrored surface to ensure visualization of the eyes and the ET tube during the procedure. The electrophysiological monitoring is set up, and the C-arm is brought in to the opposite side of where the TLIF will be performed. An occlusive barrier is placed at the top of the gluteal cleft, and the skin is prepped and draped in standard fashion. The lumbar spine is widely draped, and the midline is marked. The incision will be made 2.5 centimeters off of the midline on the more symptomatic side. The incision will generally be 2 to 3 centimeters depending on the tubular retraction system. Once the appropriate level is confirmed on fluoroscopy, the skin incision is made. Serial dilators are then used to expand the soft tissue, docking onto the facet complex, orthogonal to the affected disc. X-ray can be used to confirm placement. Once the final dilator is introduced, a depth measurement is made, and a working channel of appropriate diameter is passed over the dilators. After confirmation with fluoroscopy, the working channel is fixed to the table frame, and a final X-ray is taken to confirm location. The dilators are now removed, and the procedure can begin using either loop magnification or a microscope. Residual muscle and soft tissue is removed using electrocautery to expose the bony landmarks for decompression. A straight curette is used to define the inferior laminar edge, and a plane is developed between the bone and the ligamentum flavum using an angled curette. The laminectomy begins with Kerrison rongeurs extending from pedicle to pedicle in a rostral caudal direction. All bone should be saved for use during the interbody fusion. The decompression can be accelerated with judicious use of the osteotome to define the inferior and superior edges. A near total or total facetectomy is done to provide adequate space for the interbody placement. The decompression is then completed with a combination of rongeurs and a high-speed drill. Once the ligamentum flavum is exposed, it is carefully removed to visualize the dura and the nerve root. Bipolar cautery is used to coagulate any epidural veins, and a scalpel is used to perform an annulotomy. The initial discectomy then proceeds with curettes and pituitary rongeurs. A rotating cutter is then used to prepare the end plates for interbody placement. Dilators are introduced sequentially until the disc space height is similar to the adjacent levels. The final dilator serves as a measure for the dimensions of the interbody graft. We place the cage into the disc space and pack it with a combination of autograft and BMP after placement. Fluoroscopy is used to confirm placement in AP and lateral planes, and finally, the working channel is withdrawn. Next, we move to the placement of percutaneous pedicle screws to complete the stabilization. A parallel incision is made on the contralateral side of the patient. The C-arm is rotated for a true AP view parallel to the disc space. Bone biopsy needles are placed through the soft tissue under fluoroscopy so that they are directly in line with the pedicle, such that they appear as a single spot. This is referred to as the bullseye technique. Once the biopsy needles are resting on the bone at the screw entry points, a K-wire is drilled through the needle approximately 1 centimeter into the pedicle. The bone biopsy needles are removed over the K-wire, and fluoroscopy is used to confirm that the K-wires are centered within the pedicle in the AP plane. Once all the wires are placed, the C-arm is rotated to the lateral position, and the K-wires are advanced about 2/3 the length of the vertebral body parallel with the end plate. With the K-wires in place, the soft tissue over the wires is serially dilated and the pedicles are tapped. Cannulated screws are introduced over the K-wires and inserted under fluoroscopic guidance. Pedicle screw extenders are left in place until all screws are inserted. There are a number of different devices available for rod insertion at this point. In this example, we will be using the sextant device. The rod size is calculated using a template, and the sextant is used to pass the rod through the screw heads. The screws are then compressed, tightened, and broken off with a torque wrench. The sextant is disconnected and removed. Finally, the wound is irrigated and closed in the standard fashion. Most common complications can be avoided by meticulous technique and preparation. Some additional steps which can be taken to minimize complications include the following. If a K-wire is used for the initial localization and dilation, it must be placed onto the lamina with great care. It is possible for the wire to slip into the interlaminar space and cause dural perforation or nerve injury. This can be avoided by removing the K-wire after placement of the first dilator and ensuring that all subsequent dilators are docked securely on bone. The use of curettes to define and dissect all planes to avoid dural breach and nerve injury when using the drill or rongeurs. EMG monitoring for constant feedback of nerve root irritation or traction, and frequent use of fluoroscopy for continuous localization and accurate screw placement. In conclusion, the minimally invasive T-lift technique is a novel procedure which allows for anterior and posterior stabilization, increased fusion rates, and direct and indirect neural decompression, all through small posterior incisions. With careful patient selection, appropriate indications, and meticulous technique, patient outcomes can be improved even further.